So I am responsible, so welcome. I'm responsible apparently for demystifying neuroendocrine. I'm not sure I'll necessarily be able to do that, but yeah. But so I'm Mary Maluccio. I run the program in New Orleans, which has a very unique place in the neuroendocrine community because of the rurality of our states. We are the people that cover Arkansas, Oklahoma, Louisiana, Mississippi, the Florida Panhandle, parts of Alabama. So we get a variety of people, most of which are somewhat disenfranchised. Not that people in North Carolina aren't, but you're a much smaller state with just a tad more resources than we do. So demystifying neuroendocrine. The objectives of my talk, I don't have any disclosures. The objectives of my talk are to identify key pieces of medical information that drive decisions. And what these conferences are really trying to do for all of you is to give you the tools to ask the right questions. And if you can ask the right questions, then you can better understand the circumstances and you can understand what this means for you. Because what I tell patients is I say, I'm going to go over the features of your case that are driving the medical decisions, because if you go on the internet, you're going to get lost in an ocean of neuroendocrine that can be not only very confusing, but actually irrelevant to you. So I think it's super important for you to understand where you sit. Understanding tumor grade and stage, because that's extraordinarily important. Fundamental questions on treatment options and alternatives. Why some treatment options? I go over the same menu with almost every single patient, even if we're going to take different menu options off the menu at that time. So surgical versus non-surgical alternatives. We have some great people here to give you kind of the nitty-gritty on each of the different subtypes of treatments that we use, surgical and non-surgical and chemotherapy. And then when a second opinion may be necessary. And I would say that last year I was up here saying, hey, I think during the pandemic, all of the neuroendocrine subspecialty centers, all of the neuroendocrine subspecialists were allowed to give opinions over the virtual platform to almost any person in any state. So if we do or do not follow what's happening, is that there is some risk that they're going to take that virtual ability away from us. So we got it in the continuing resolution. I think we're good for around 6 more months, but I think that it is one of those things where you need to lobby your representative, because I think unusual cancer diagnoses will often need subspecialty medicine that's not directly available in your town. So the net basic are that few cases are exactly alike. I think it's really important for you to understand where you sit in that ocean of neuroendocrine. You need to identify the medical decision making in your case. You need to understand the tumor grade and stage. And the reason why that's important is that in neuroendocrine, the grade that we use, that's the KS67 number that's on that pathology report, the grade is often more important than the stage. What that means is that you can have a stage 4 neuroendocrine that is a low grade that will do better than a high grade neuroendocrine that is an earlier stage. The pathology report includes very important information. I'm going to go over the easy information and then some of the little nitty-gritty information that we may not comment on, but we do actually look at. And there are many treatment options, and none of those options are mutually exclusive. We can use them in combination, we can use them as complementary, or we can use them as individual treatment options, sort of similar to other chemotherapy other therapies where we would use one first and then go on to the next. Oftentimes in neuroendocrine, we are sometimes using them in combination or complementary. And when a second opinion matters, and I think we have Aman Chauhan in PRRT talking about the importance of clinical trials. I think for a lot of patients that don't really understand clinical trials, there are a number of clinical trials that are extraordinarily relevant to neuroendocrine. They are not like, oh my God, we've never tried this in your disease, so we're just going to give it to you. We don't even know what it happens, and we're going to see whether or not it makes you really sick. No. That is not the case at all. Obviously, we do have some early phase clinical trials, but a lot of the clinical trials, including Mr. Ray's Bio over there, Exelexis, these are clinical trials that are coming down the pike that are extraordinarily relevant to neuroendocrine. They are kind of tried and true, meaning they have a lot of evidence to support them, and sometimes in some of the poor and disenfranchised part of the country, clinical trials is the only way we can actually get people onto any therapy, no less standard of care therapy. So it's really, really important for us to be able to give people novel therapies. So identifying key drivers of medical decision making. Tumor grade, the primary site, is also very important. So although someone may say mine was in the ileum, well, that's really the midgut. So when I tell people, you don't necessarily need to remember the word midgut, I'm going to put it in your thing because that's one of the 4 words you need to look up on Google when you're doing all your research. So the primary site is going to be foregut, which is going to be all the stuff from sort of the diaphragm up, and then the stomach and duodenum and the pancreas. And then you're going to have the midgut. And then you're going to have the hindgut, which is really just rectal. And then you're going to have bronchopulmonary, even though bronchopulmonary in some days is included in the foregut, is that it's really a category and it's of its own. The extent of disease. I need to know where it is and how much of it is in each of those organ sites, because we may be doing liver-directed therapy for someone that has pretty life-limiting disease in the liver, where we may be saving that and using PRRT when the most of the disease is in the bone. Treatment options depend on the involved site. The SSR avidity, that's just the hotness on that PET scan. I'm going to explain that in more layman's terms on how we are looking at those PET scans and how you can interpret your PET scan. In general, hot on our PET scan is what we want. Hot on FDG PET is kind of indicative of a higher grade tumor, so that the avidity on our PET is very important in decision making. And then each person that gets a diagnosis is going to come with a suitcase over here. And that suitcase has a number of other medical problems that may actually influence your ability to tolerate some of the treatment that we are doing. And so therefore, if our goal was not to have it be a trade-off of one problem, the current cancer that you have, for another problem that is the consequences of the treatment, especially for people that live a long time. So comorbid conditions are just the other medical conditions that someone may have, medications they are on, or issues that would keep them from recovering from a surgery or tolerating some of the treatment that we have. So we really kind of have 2 dichotomies. We have low grade and we have high grade. And then I'm going to just go immediately on to the next slide because I bolded the things that have categorized into how we make decisions. So the bolded categories are going to be what we consider the well-differentiated. So G1 and G2 are going to have a Ki-67 that goes up to around 20%, and they are, for the most part, usually PET avid on the somatostatin receptor PET. G3 well-differentiated is a category in and of itself. It's probably one of the more debatable categories because we can't seem to agree on exactly how we should be managing these patients. So sometimes G3 well-differentiated will behave a little bit more like the lower differentiated subtypes, and sometimes G3 well-differentiated will behave more like the higher grade, more aggressive subtypes that would potentially need chemotherapy. So if you have a G3 well-differentiated neuroendocrine in your small intestine, we are likely to treat it more like the lower grade. And if you have a G3 well-differentiated neuroendocrine in your pancreas, we tend to treat it more like a higher grade. But if I were to tell you, when do you think you should get a second opinion? If you fall into that category where we just don't have, even within the neuroendocrine community, really good standards that we all go by, and so you may find yourself getting differences of opinion. And then you have the G3 poorly differentiated. Those are the neuroendocrine carcinomas. In general, we will usually at least start with chemotherapy, and then there are going to be some clinical trials out there are looking at certain categories of people that, for whatever reason, will have somatostatin receptor avid tumors, for which we would consider some of the PRRT options. And then within the high grade, you have small cell type and large cell type, and those are how we dictate what types of chemotherapy we would give. So additional information from the pathology report is going to be the primary tumor. It's going to be whether or not there are lymph nodes, the number of lymph nodes, and the total removed. So that's how surgeons can determine whether or not we've given you a really, really great operation. We would like to have the positive to negative ratio be something where you've got more negative than more positive, because lymph nodes are like a big spider web in your body. And so if you have 7 out of 8 lymph nodes removed and they're all positive, well, we have a little bit more suspicion that one little one like right over here is going to be number 9 that was left in your body. So that's why when people, and there's any suspicion that maybe we have some disease left behind, we will follow that operation with a somatostatin receptor PET to determine whether or not we have any additional lymph nodes. Doesn't mean we jump back into surgery, but it's really important. So the number of positive over the total removed. The margin status, we would like to have negative margins. We'd like to know that each ends of your small intestine were negative, and the mesentery, where the lymph nodes are taken, are negative margins, meaning that tissue is normal. You would like to have, is it one tumor in the intestine or is it multifocality? That also matters. Is it one tumor in the pancreas or is it multifocal tumors? So that's just like the whole intestine is like a big lawn, and you have a big weed on the lawn, and you went in with surgery and you took a big shovel and you took out the weed. But if you go out and you say, honey, I think I see more weeds, your confidence that you can truly remove all of that surgically, or your confidence that you won't recur, just goes down a bit. And it doesn't mean that it changes significantly what we do or how you do. It just does change how we survey you and how we put expectations into what is likely going to be necessary over the course of your life. Vascular invasion, that's at the microscopic level. Have these cells managed to invade through into the vasculature? So vascular invasion is a predictor of recurrence in any type of cancer, but in neuroendocrine, it's going to be an indicator of local recurrence or distant metastatic disease, even if that metastatic disease, like in midgut neuroendocrine tumors, tends to manifest several years later. Perineural invasion is a little bit more, it raises suspicion for your risk of local recurrence, not as much metastatic disease. And then the regional involvement, the number and size, so how we stage it based on our national staging categories, which is the AJCC staging system. The size of that mesenteric involvement in a midgut primary actually matters. And then obviously evidence of metastatic disease and where that metastatic disease is. So there's regional involvement, primary site, unifocal versus multifocal and extent lymph nodes, and then there's metastatic, of which we really do liver only because we've got a lot of liver-directed therapies that you're going to hear about, or is it multi-organ site involvement, where I think Dr. Chauhan will talk about how we'd be more likely to talk about systemic therapies, including PRRT. So I have 2 slides on definition, so you're going to ignore the second one. So I think it's also important when you understand how we're making decisions in cancer, regardless of whether or not it's neuroendocrine. So if you're at a cocktail party talking about cancer, it's really the same. So when we say that we're going to do something with curative intent, it's usually within the surgery category. It can also be within the liver-directed category, to be honest with you, because there's a lot of data that many of the liver-directed ablative techniques that we do have been comparable to surgery. But curative intent means that the procedure is meant to give you every opportunity to be cured. We want to eliminate this as a variable for the rest of your life. So something done with curative intent, let's just take pancreatic cancer, not pancreatic neuroendocrine, pancreatic cancer. So we operate on pancreatic cancer even though the outcomes in pancreatic cancer are uniformly quite poor. But that we still do operate because there will be a small subset of patients, maybe 5%, maybe 4%, maybe 6%, that will ultimately have it removed and live to die of something else. We then theoretically cured them of that cancer because that was not the driver of their mortality. So curative intent in neuroendocrine is a little bit more difficult because a lot of times we do have either multifocality or metastatic disease, but it doesn't mean that there won't be cases where the surgery is meant to eliminate it as a variable over the rest of your life, meaning that you would live to die of other comorbid conditions. Palliative intent and prolongation of life is really where we sit in neuroendocrine. Palliative intent just means that we are doing the procedure to try to alleviate symptoms or potential symptoms related to the disease or potential growth of the disease in a very awkward area. So then we would talk to you about the fact that we would say, oh, is the operation, is the liver-directed therapy, is the PRRT, is the targeted radiation, is that going to alleviate a problem? Okay, well, first then you've got to identify the problem. Is it pain? Is it obstruction? Is it bleeding? Because you can't do something with palliative intent just because we have a diagnosis. because then you'd never know whether or not you were successful. So you say, I'm going to do this with palliative intent. I'm going to operate on you with palliative intent, and therefore, regardless of whether or not there is prolongation of life, which oftentimes there is, but regardless of whether or not there's prolongation of life, if we alleviate the pain, we have met that goal so that you can understand what you are investing in the process, so that by investing in this process, we are going to alleviate this, dysfunction, this, this pain or this bleeding. Now, if someone has something growing in an awkward area, like in the liver, things can be done with palliative intent because we say, hey, you know what? Growth of that area in the pancreas, in the stomach, in the small intestine is, oh, sure. We can say, yeah, even slow growth over time is likely to cause obstruction, bleeding, problems, malnutrition. So that counts. So if we say, oh, we're gonna offer you an operation or a treatment because we believe it will keep something from happening, and if by keeping something from happening, you will then not get one of those things happen, that also comes into palliative intent. And prolongation of life is how we deal with cancer in general. So why we give chemotherapy after colon cancer resection is for prolongation of life. So a lot of what we are doing in neuroendocrine is you are investing in prolongation of life, meaning that the treatment that we are giving or the recommendations we are describing is meant to have you live longer than you would have lived had we not taken that off the menu. So there are many of the things that we do in cancer with prolongation of life. They are not mutually exclusive. I think I mentioned that. You have a number of different treatment options, from the somatostatin receptor analog therapies, which are standards of care, liver-directed therapies, of which I think that Dr. Marsala will cover that, peptide beta receptor, chemotherapy, and then obviously surgery. So these are so all the patients that come and see me, here's my parking space analogy, because most of what we do in neuroendocrine has a lot to do with whether or not we have a receptor or we don't have a receptor. So neuroendocrine tumors, especially in the G1, G2, and G3 well-differentiated categories, will have a preserved receptor. So that is, I call it a parking space. So sitting on the top of these cells is going to be this receptor. And a lot of the therapy that we are doing is targeting that receptor. And so when you were to think about then the effectiveness of that therapy, if we can effectively get that therapy to that receptor, and then the cell is then going to come under the influence of whatever treatment we are giving, then we would be effectively able to treat that tumor using the receptor. So a lot of the difficulties that we have is that there will be some cases where the treatment will totally work for years of time, and then the cells gets just smart enough to say, you know what, this receptor is a handicap for me. So I need to somehow try to figure out how I can try to evade this whole receptor thing. We call that grade migration, is when the cell is trying to figure out how to get around the fact that we know its vulnerabilities on that receptor. But that also that receptor is what drives symptoms. So you will do something, stress, eating, temperature changes, whatever it is, you can't wake up in the morning without your neuroendocrine system waking up with you. And then you're going to raise natural chemicals, neuroendocrine chemicals in your body, and they are also cars looking for that receptor. And it's going to bind to that receptor, and it's going to then signal through that cell. The cell is going to be, sweet Jesus, we're up. And then it's going to spend out more chemicals, and then it's just a vicious cycle. So if you were to look at somatostatin receptor inhibitors, that is merely just injecting you with a bunch of little cars that are searching for that receptor. And what I tell people, it's just like a police officer putting a boot on the car. It's trying to cripple that cell. It's trying to keep it from being able to signal. It's trying to keep it from spewing out the stuff that gives you symptoms, and it's trying to mess with the mechanisms by which that cell divides. So if you have, 100 parking spaces and you're sending in 200 cars, all is good. You're going to be able to block those receptors. So the reason why this works is because those cars look exactly like the normal chemicals, but when they bind, they clog the parking space so that your normal chemicals then can't bind, can't signal through the cell, and therefore it's not a self-fulfilling prophecy. So really the balance between somatostatin receptor analog, the dose that you can get in there, and the adequate suppression of those cells can be all that people need for years of their life if they have somatostatin receptor avid tumors. Well, using that analogy, and in many cases, I will look at a case and I would like, okay, well, if I've got 1,000 parking spaces and the dose that I'm giving is the equivalent of 200 cars, you're like, I think that the odds of our being able to manage this extent of disease with somatostatin receptor analog therapy alone goes down. And therefore, that's why we will use some of the treatments in complementary. We will use them in combination in order to try to drive down the number of parking spaces with other therapies, so it gives this therapy a better chance of being able to manage the disease in the long term. So surgical resection is just like taking a little shovel. So very primitive. So surgical resection means that you're looking at a problem and saying, can I resect that? Can I take that weed out of the lawn, effectively eliminate it? Obviously, that comes with a 100% response rate, but it also comes with a lot more investment in that therapy. So this is just one. The only reason, if you were to take pictures of these slides, the only reason that I chose this thing right here is just to show that you can understand where you sit in the bigger scheme of surgical resection. So surgical resection, say for example in cytoreduction, we're taking out lymph nodes, we're taking out liver tumors, and we're taking out pancreas, is really about eliminating sites of disease, and it's very effective at getting rid of a lot of parking spaces all with one go. So but what I tell people when I say, okay, there's ample evidence to support surgical resection in patients with metastatic neuroendocrine tumors, then I say the strongest data is in small bowel. So if you were to, if you were to look on this thing, the vast majority of people are in the small bowel category. So of all of these 1,000 cases on this large series of people that have been operated on, that the vast majority were small bowel. Well, the vast majority of neuroendocrine is small bowel. So that's not, uncommon. So then you'd say, well, what's the second thing? The second one is pancreas. So then I'll usually say the strongest evidence is in small bowel. Well, that's because we've done a heck of a lot more small bowel. And then the second strongest is in pancreas. Pancreas, as you get up to G3, not as much evidence. Doesn't mean we never do it. It's just that we want to be going into that decision with our eyes wide open. So surgery is really about cytoreduction, meaning you don't have to take out every cancer cell in order to have a survival benefit, but that we need to know where people sit. So when we're doing metastatic cytoreduction in patients with metastatic bronchopulmonary, oh, sure, we're doing that with far less data. Doesn't mean that we never do it. It's just that we say, hey, where does this fit in? And all of the other menu items of that kind of the rare of the rare within the neuroendocrine. And then, although this is our data, there are many large neuroendocrine centers that have corroborated this data. We all feel very similarly about surgical cytoreduction. Embolization. So, sorry. You're going to hear a lot about liver-directed therapies. Embolization, the analogy that I do that's like going to the state fair and you have that little arcade and you have your little air rifle and the little targets come up and you shoot the targets for points. So a radiologist can go in and under image guidance, they can guide a catheter and they can seriously, literally say, I'm going to go for that tumor and that tumor only. And the liver is like a tree. It's got a very predictable anatomy. These tumors rely on the oxygen coming from the artery, so they go in through the artery, not dissimilar to how we put stents in the heart or we deal with aneurysms in the brain. We just take a little turn towards the liver, and they're able to either go as close to that tumor as possible. We call that super selective, and take out an individual tumor. Well, the beauty of that is you get virtually no treatment effect in the surrounding normal liver. Okay? Or if you have small volume disease and you got 3 tumors that are sort of in the same segment of the liver, then they can shoot those particles from a little farther out and get 3 tumors with the same, treatment. And so the interventional radiologists that do a lot of these have a really nuanced approach to how they can effectively do it. But 80% likelihood of being able to get rid of individual tumors. So very good non-surgical way of getting rid of parking spaces so that you can then have the somatostatin receptor analog able to manage a smaller volume disease. So there are ablative techniques. So they come in a lot of different varieties. And so when you are talking about different types of ablation, ablation is pretty much like taking the weed analogy. You go out onto a lawn. These are also limited to the liver for the most part. And you're using that weed killer that stares at a weed, and you do the one that kills the weed all the way down and then kills the lawn around the weeds. Then you have a big brown spot where you previously had a weed, because it literally gets the entire thing. So ablative techniques are very good at individual weeds. Not as good if you've got a bunch of different ones, because that I call the whack-a-mole. If it's a whack-a-mole, you're just taking individual tumors as opposed to being able to do a lot of tumors in one go. But they come in radiofrequency ablation, microwave ablation, irreversible electroporations, meaning we're just using an electrical current. SBRT is a targeted radiation like we use in the brain, and then a lot of buzz on the use of histotripsy. I think we have emerging data on its value in neuroendocrine. That has come up at almost every neuroendocrine conference since histotripsy came onto the market around 18 months ago. PRT, you will hear from Aman Chauhan. That is just taking a little car, and on top of that car is a radiation particle. You are infusing it like IV fluids. It is driving all the way over your body. It is binding to that same parking space, and that cell is just dumb enough to swallow that radiation particle like a whale. The radiation is internalized. It damages the innards of the cell and damages the DNA. And the advantage of PRT, it's very targeted because it's going to only be limited to what binds to that cell. The disadvantage of PRT is that you can't tell it where to go. So liver-directed therapy, you're like, boom. SSRA, the injectables, yeah, you can't really tell it's going to distribute based on the somatostatin receptor avidity, but you are injecting systemic radiation therapy. I mean, you got like radiation particles going all over the place searching for these things. And so there are some times where you say, oh, I wish it would have gone to the bone, or I wish it would have gone to the liver. So the nuances of PRT is that if you have a lot of the bulk of the disease in the liver, but that we also have disease in lymph nodes and bone, many of the subspecialty centers will use liver-directed therapy to beat down the liver. And I just say that we're just trying to redirect the PRT to the sites of disease that we don't have good targeted therapy for. So PRT we can also use in combination with other therapies. So PRT is not really meant to have it show dramatic changes, so especially with beta PRT. So you look at an image and you've invested in this therapy and all of the side effects associated with it, and you say, oh, doc, how does the imaging look? And you're like, oh, good news, it looks the same. And you're like, oh, that's not what I thought. And you say, yeah, but then I usually say it's kind of like having the car in your driveway, but that the damage of the DNA has really damaged the engine of the car, so the car may be sitting there, but it can't drive. We do have a lot of work going on in the lab that's trying to better understand whether or not we could read that signature in the blood so that we could better understand. I was like, no, I'm going to promise you it really did work. You can see your signature here, and then you can see after PRRT, you can see that it did change towards a more normal signatures. So there's a lot of work going on how we could assess the response to PRRT. I think some of the buzz and the optimism with alpha particles, like the Action 1 trial with actinium-225, is that it is associated with a higher response rate. And so with that higher response rate, even though alpha particles are a little bit more of an investment for the patient from a side effect profile, I will tell you that patients usually are almost a little bit more satisfied. Like it's almost worth it, the investment in it, because they actually see a PET scan that shows that there really is a substantial response rate. So what we're finding with alpha particles is that the response rate is significantly higher, upward towards around 50% objective response rate, and then obviously the stable disease rate is still a very important factor. It's just not as relevant to beta PRT, and I think Aman Chauhan will cover that. And then chemotherapy is just poison. So cytotoxic chemotherapy is just trying to target cells that are word finding difficulty, dividing at higher than average rates compared to normal cells. So you're trying to just poison the cancer cells more than the normal cells. It is the standard of care for intermediate grade and higher grade tumors. Well, that's because those cells are dividing at a rate, and chemotherapy requires the cell to be dividing in order to get the poison in. So you can understand that if a cell is dividing really slowly, the Ki-67 is less than 10%, the cell is dividing so slowly, well, you'd have to have the chemotherapy on for like years of time before enough cells would divide to get exposed to the chemotherapy. So in general, we don't use it as much in lower grade tumors, but that we do use it in higher grade tumors where it's more likely to be effective. That's the definition slide that clearly late last night I was this. So 5 issues you should discuss with your physician. 1, priorities in care, meaning your case, your disease, your symptoms, your life. So a lot of times in cancer, we're trying to standardize. We're trying to say this is what we do for hormone receptor positive breast cancer. But really in neuroendocrine, it is absolutely about what we do in low grade, well-differentiated mid-gut neuroendocrine tumor, but it really is what we do for you. Because some people will say, I don't really have any symptoms. Some people say the symptoms are paralyzing. So there's quality of life features of neuroendocrine. Okay, then there's active cancer treatment. That's your investment in quantity of life, of which you're going to hear about all of the things that are clearly associated with quantity of life. Unique drivers of medical decisions in your case, the little suitcase of other comorbid conditions that may influence your ability to tolerate some of those things. Put multiple treatment options in perspective. That's why we all talk about tumor boards. That's really the checks and balances of our government, meaning our medical government within cancer. The checks and balances lie in the tumor board. And a tumor board is a tumor board when you have appropriate people sitting at the table. So that's usually medical oncology, radiation oncology, surgical oncology, interventional radiology, nutrition services, palliative care, medicine. Sometimes it'll be hepatology if someone has some liver dysfunction associated with their liver involvement. But you need to have enough people around the table to keep us all honest. And then clinical trial opportunities, tumor boards that are NCI or COC accredited, meaning that we're supposed to all be doing it the same way, are supposed to look at clinical trial availability. And if you're doing your job really well, which I think is what we expect out of neuroendocrine subspecialty centers, is that we should be able to know what's happening in Miami. I should be able to know what's happening at Atrium. I should be able to know what's happening at Moffitt with John Strasberg, because it is something where we can feasibly send people across state lines. We have actually used philanthropic dollars to send people to MD Anderson to get one of the drugs that they have on trial. So I think that if we were really doing a stupendous job, it would be to look at clinical trial availability nationwide. And yeah, one of my main problems is that people within the South do not want to go to New York. They'd be like, you are not getting me to go to New York. And so you kind of have to look within your region. I think Dan Halpern showing up at Emory, I think is going to do us a lot of good, because then I would be like, will you go to Georgia? So we have some challenges of that, but we have been able to convince people to take an opportunity when we felt that it was really in their best interest, but something we couldn't do closer to home. So my advice: treatment plans for NET needs multidisciplinary input. The program should function with all different specialties giving complementary recommendations. That's the tumor board summary. This is going to be my I'm a surgeon snob thing, is that I do believe that the surgical opinion, good or bad, we should operate or we shouldn't operate, should come out of the mouth of a surgeon. And I think there are a lot of programs where that is saying, I ran it by my surgeons, or I did it at tumor board and the surgeon said that you were unresectable. But that I think that that's a cop-out on the surgery side, because I think you can have someone that absolutely looks resectable, but very weak. So the surgeon sitting at that tumor board saying, sweet, I can totally operate on this person. Then the medical oncologist says, oh, look, they can operate on you. And then they show up in the surgeon's office and they're like, oh, I think you're weak, like, I think we're going to hurt you, whatever. And it's just not, they should just all see at the same time. And so the surgeon should be telling you all the reasons why we would, why we wouldn't, why we'll wait, why we'll do this first. But I just strongly believe that it should come out. And I would say that even if I wasn't a surgeon. So I think that's one of the several reasons to get a second opinion, is if you feel like they're like blowing off certain options right off the bat. Like if a medical oncologist is coming out and just saying, oh, we need to treat you with this. And you're saying, oh, but I went to this conference and we talked about all these other things. They're like, nope, we're going to treat you with this. That's where I think that patients are sold short. And I think that the medical decision-making can't be out of one days. And then it can be used alone and in combination. They are not mutually exclusive. We use them in complementary all the time. Don't hesitate to ask questions about what features go into your case. Meaning, can you just explain my case with respect to neuroendocrine, so then you can better understand that maybe what's driving it is going to be something unique to your particular case where the disease is. That's why we usually write a very lengthy note to the referring physician, because that's how I not only educate the patient, but the referring physician. Because if you get two patients that look seemingly the same, and then you make one decision on one patient and then one decision on the other patient, they're like, oh my God, she's so schizophrenic. Like, can't you make a decision? And so I think it's just really important for you to understand about you. And then keep copies of your records. So I live in a world where we can't even get pathology reports because apparently they went away with Katrina. I don't know, they're like, in the bottom of Lake Pontchartrain. So I think that keeping copies of your records, I don't think you need to come, like some patients will come with like a really, really cute binder, but that I do believe that like critical pieces of information, like a pathology report and stuff like that, it makes the second opinion a lot easier, and it also allows you to understand your case better. So radiology reports, pathology reports, operative reports. I don't think you need your vital signs from every office visit that you had. But I think that there are very important stuff that is relevant. And then email me with any questions or concerns. And I don't know what this clock is doing, but I'm 3 minutes early. So.